Well, welcome everybody. Appreciate you showing up with us here early mornings and get this very good sessions of AASLD going. I'm really pleased that AA has made such a good effort to engage patients this year. It's far better than last year and huge improvement. And I really value having opportunity to do this. When they asked me to maybe do this session, I thought about what this is. I'm a NASH cirrhosis patient, and it's an amazing world that we have because I'm older than NASH. Many of our patients are. It was not even identified as a disease until 1953. And I'm a fair bit older than that. So I thought that was, that always has struck me as I think about how rapidly our society has changed, and something that I think is that perhaps that we can make some progress on this in this talk is the very nature of our relationship with our physicians has changed so dramatically in my lifetime. I mean, I came from the age when we had a family doctor. My doctor, before I went to college, delivered my mother and delivered me and took care of our family, and they knew us. My doctor was somebody that I really got well acquainted with over the years. And as medicine has advanced, a lot of things have changed. In those days, although they were close to the family, what they did, the tools they had were really modest. As we look back, they couldn't do much, fix it, patch up a cut or set a bone, or, they got this miracle penicillin when I was a kid. And they basically helped us be born, and they held our hands when we died. Today, we have so changed that relationship. The physician has become part of this vast medical machine. They're largely employees. We don't have a real relationship that we used to value so much. And something that I think we're in danger of losing is that the doctor-patient relationship is the only human relationship where, excuse me, we deliberately, we choose to give another person the right to do things to us that may kill us. Now, that is a profound relationship, and we are fragmenting that as doctors become cogs in the corporate machine, and they become pieces of the puzzle. It becomes harder for us to have the kind of intimate relationship that we really value as patients. And so as we think about the doctor-patient relationships, reflect on that. And what we're seeing in the patient world today is this push to wellness, to claw back the relationships with the doctors, to engage in these wellness efforts. And I think that is so important, because what we have lost in this amazing evolution of medical knowledge is such an important part of the human relationship. And that's something that is more valuable. If we let it be lost, it's a greater loss than we perhaps understand. So next slide.
Sorry, I'm trying.
Zoom is.
There we go.
Okay. So just to give you a sense, there's something that I hear hundreds of times a month about how cirrhosis is a death sentence. People live in great fear of cirrhosis. And this is my journey. That ugly picture in 2010 was when I had a gallbladder surgery, and that's a really gnarly liver, and an example of the things that we're hoping to make progress on is that in spite of that, and in spite of having a biopsy, I was actually diagnosed as having a perfectly healthy liver and sent on my way. And it's the kind of thing that happens to liver patients, in that we are often undiagnosed. We are often misdiagnosed. Our symptoms are not good enough, not understood enough. The relationships aren't really a part of medical care to the extent that people take this journey through NASH seriously until you get acute symptoms. And that's when, in modern medicine, it's can I do a treatment? Can I prescribe a pill? Is there an action I can take? And so in 2015, I finally had something that medicine considered to be useful information, and that's a biopsy of in 2015, and you can see that's very clearly cirrhotic liver, and I was a definite stage 4. And the graph on the right there is my test results over the years. So I started out with a FibroScan of 21, and in those days, the doctors were saying anything over 12. They're more likely to say anything over 14 today, but clearly I wasn't in liver hell, but I could see it from where I was. And that just scared the bejesus out of my wife and I. But we were fortunate in that, unlike so many of us, we got appropriate advice on next steps. We got guidance at that time, at that crucial time when we were able to internalize our problem, decide on a course of action, and we followed it. And so over the next couple of years, you can see that my fibrosis began to resolve. And today I'm at that 9.6 level, which is, not unrisky, but I'm right at the border of the 3s. And this is a huge success for me personally. But I hear so often patients say that, or are told that there's really nothing they can do. And so I basically want to just kind of give my testimony that this is not something that you have no control over, no possible reaction to. But the journey that I went through, you can see that I saw a lot of docs, and up until I got to a place where doctors could say, "Oh, you have this symptom, now I can do something." And that's a journey that that Sue is going to talk about, because we need to find a way to better integrate what we know and better ways to manage the disease process. So next slide. So Sue is a doctor herself, but she's also a patient, and she has a lot of experience in working with viral hepatitis programs, and she's got a medical degree from Miami and Johns Hopkins, and she's worked at Georgetown and worked with the CDC, and she just has a very impressive resume, living with Hep B and working with WHO, and she's led a lot of initiatives, and so Sue has been through the whole gamut of the patient journey as well as the physician journey. So I think we're really fortunate to have Sue with us today. So next slide.
I can take it from here, Wayne. I've got the title of my slide after the intro. So, but thank you for that great introduction, and Wayne, especially for sharing your story. I think it really highlights a lot of the important issues that I want to bring up today. And I think you are giving light to why focusing on these partnerships is so important. So thank you for really sharing your journey with us. So I just want to say I'm very honored to be here today. This is actually AASLD's first ever patient track keynote. And last year was the first time we had a patient and advocate track. So I want to thank AASLD and all the organizers for all your hard work in planning this meeting, and especially just for this great lineup we have. So I want to make sure everybody is aware of what all is there. This was all put together by our patient advisory group. Each of these sessions features a combination of our patient community members right alongside our AASLD leadership, physicians, and other members. So you can see we've got 9 great talks, which hit on really important issues, which haven't always made it to the liver meeting stage, but are important to patients. We invite providers to join because we believe that here at the liver meeting, we're here to learn from you, but we hope you will also take this opportunity to learn from us. And we've got 8 great abstract tours and many engagement opportunities. And as we saw yesterday, the community conversations was a big hit. So I'm sure you guys will be continuing that. And I just want to acknowledge that all this fits into the larger picture of AASLD and the foundation strategy, which has as one of the 6 pillars to engage patients with the aim to inform the work of AASLD and to improve health outcomes. So what I'll be talking about today is how partnerships between patients and physicians can improve and have an impact on liver disease care and research. And as Wayne mentioned, I'm a dual citizen, as I call myself. I'm both a patient and a physician. And so I'll kind of be going back and forth talking from both perspectives. So this is basically the layout of the talk. So we're going to talk about how partnerships are at the heart of this. And I'm going to go through different layers of this. And first, I'll talk about how partnerships can optimize patient and physician relationships and care. Then we'll talk about how partnerships can improve liver disease care and research and drive awareness and education. And finally, how these partnerships will make an impact on advocacy and policy. So let's talk about what happens in that patient one-on-one relationship and the kind of care that happens. And I think, Wayne, you did such a great job of just illustrating how things have changed over time. And it's important for us to take a step back, I think, and to really talk about whether us as clinicians, whether we're approaching our patients focused on their livers or on them as patients. So are we liver-centered or patient-centered? And of course, the reason they may be coming to us may be because of the liver disease. That may be the focus and the reason. But what we get in front of us is actually the whole person, which is so much more than the disease. So what is patient-centered care that we talk about so much? And this is something that the Institute of Medicine has really honed in on as being important, that if we are to improve the quality of healthcare, we really need to focus on patient-centered care. And medicine has evolved, as Wayne has mentioned, but also the model, not just the way it's delivered, but also the model of care. So we've moved on from that paternalistic model where it was considered that the doctor knows best, and that as physicians, we would be dictating the course for the patient. What is patient-centered care? Well, it's care that is respectful and responsive to the individual patient preferences, needs, and values. Patients should have necessary information and the opportunity to have a degree of control that they choose over the healthcare decisions that affect them. So our health system should encourage shared decision-making, and it's so important for clinicians and patients to really work together. And it's been shown that this is what leads to the best outcomes. So what is shared decision-making? It is a collaborative model of clinical decision-making. We should be combining, as you see here with the Venn diagram, evidence-based medicine, provider clinical expertise, and patient values and preferences. So if you are a physician, these might be some of the steps that you take. So step one, seek your patient's participation, communicate that a choice does exist, and encourage your patient to be involved in the conversation. So this may be a little bit like what we do with our kids. You don't just ask them, what do you want? You might ask them to choose between a few options. So as an example, if a patient comes to me and has, I get their lab results back and they have high cholesterol, and I'll tell them that we need to come up with a plan. So step two is to help explore and compare treatment options. So I'll let the patient know that their cholesterol is high and that they are at risk of heart disease, and we need to come up with next steps. So in my mind, and for my medical criteria, I might be thinking, oh, they really need to start a statin, they qualify for medication, but I'll ask them if they're ready to take that medication, or if they want to be more aggressive with their diet and lifestyle and maybe repeat labs in 3 months. So step three, we assess patient values and preferences. So I might see and recognize that this patient in front of me has some hesitation about being on medications for the long term. And they're telling me that they think they can do better with their diet and they want to try that first. So step four, we reach a decision with the patient. So the patient and I, we conclude that we are going to focus on lifestyle changes, and we will recheck their labs in 3 to 4 months and not start meds for now. So this is important as a step, because even if I think the patient might have familial hypercholesterolemia and they are destined to end up needing therapy, it's important for the patient to have had a chance to see the effects of their efforts and to actually try to see if they can make improvements on their own. So step five is evaluating the patient's decision. And this is very reasonable for this scenario. And we might have this patient, when they come back, we might find out their lipids have improved and they may not need medication, or if it's still high, that we actually do need medication and they're more agreeable to at that point. However, for some decisions, especially in urgent cases, a patient's choice may not necessarily be as reasonable. And it would be my job as a physician to really indicate that in my communication with them. So I like this article that Wayne had actually found about practices that physicians can take in fostering physician presence and connection with patients in our clinical encounter. I think especially in this era of EMRs and computers and just so many logistical steps we have to take in order to deliver care. And so much of our focus is really just on documenting. These are really important reminders on how we can develop a strong connection, even if our visit is short. So first is preparing with intention, familiarizing yourself with the patient you're about to meet, creating a ritual to focus your attention before the visit. Might just be a quick chart review before you go in. Second, listen intently and completely, sitting down, leading forward and positioning yourself to listen, not interrupting, which I know we're really good at, and recognizing that your patient is the most valuable source of information. Next is agree on what matters most. So finding out what the patient cares about, incorporating these priorities. So I often will ask patients, what do you want to make sure we accomplish during today's visit? So I know what's most important to them. Connecting with their story, making sure you understand the circumstances that influence their health, and acknowledging their efforts and celebrating success. And then finally, exploring emotional cues, noticing them, naming and validating their emotions in order to be a trusted partner. So, and then for the patient side, here are some practical tips, I think, I've learned in just seeing so many patients and how to optimize your own care. So number one, be your own healthcare advocate. Nobody else is going to do this for you. Number two, know your own history. I think Wayne did a great job. Obviously, you've been collecting your data, your biopsies, pictures of when you had your gallbladder removed. I mean, that's impressive. You have all of that. But I tell patients you have to consider yourself as your own medical records department, especially if you're seeing doctors that are part of different hospital systems, or some may be private, some may be employed. And if you don't already know by now, our healthcare system is not well connected. And so it's really important to get copies of everything, or at least have it available on your patient portal and be organized. It's really worth it. Number three, have your questions ready for a visit. I did this when I was going through some medical issues, is just making sure I wrote everything down so I wouldn't forget. Summarize and clarify the instructions that are given to you if you are not clear. There's no shame in that. It's really important that when you leave, you understand exactly what the plan was and what the intent is. So it is important also to bring up any concerns you have, or any reluctance that you might have with what was suggested, or any limitations if you don't think you'll be able to follow up. And I think this is so important. I think people don't realize, rather than just, if the doctor tells you something and in the back of your mind, you think, I'm never going to do that. Like, it's really important to let the doctor know, because we can modify our plan. We all want the best outcome, but we need to know what works for the patient. And when patients are silent, it often just we think that means they agree. So it's important if you don't agree. And then next, of course, follow up on any orders that were given, blood work, imaging, scheduling your next visit. And it's important, finally, just to stay connected. Ongoing monitoring is really important, especially in liver disease, which often is asymptomatic, because we are doing the tests and the things we need to in order to make sure we detect any changes, if there are any, so that if you need to start medication or we need to scale up treatment, we're able to do so. All right, so next we're going to talk about partnering to improve liver disease care and research. So how do we overall improve our overall care and better reach people in our efforts? I think we do need to recognize and address the barriers. There are many barriers to healthcare engagement. Obviously, the complexity of the healthcare system, especially in the US, the fact that it is very time consuming and people have many other things on their plate. The costs that are involved, and insurance and co-pays and co-insurance and out-of-pocket expenses, people having high deductibles, all that really plays into whether or not people can stay into care. A lot of other barriers in other populations, such as language and stigma, even approaching the healthcare system when you don't feel well, or you feel like you're part of a group that is often stigmatized. That makes it very hard for a patient to even end up in your exam room. And so I think we often think that people who need care end up in the room with us, but it's not the case. So many people aren't even able to take that first step in. So let's recognize that there are many thresholds that patients have to pass in order to get care. Those phone calls, being on wait times, having forms to fill out, getting pre-auths, more wait times. And so it's a success sometimes for people to even end up in our exam rooms. So let's increase the ease where we can, simplify care, increase access. Telehealth has been really amazing with COVID, and it will continue. Electronic communication through patient portals, combining our services, as much as we can, doing more than one thing in one visit, integrated care between primary care and specialists, even simple things like medication delivery, trying to get people 3 months, 6 months, a year supply of their medication, or having it sent to them as opposed to them having to pick it up. All these little things make a difference. So I just want to say that I'm not going to have time to really go into a lot of this, but we're seeing a lot of these changes, I feel like, in Hep C, like the kind of revolution that's happening with Hep C care is just a great example for what we can do with other liver disease too. So just in a short couple of years, we've come to a treat all approach, simplified regimens, 8 to 12 weeks that are oral, high cure rates. CDC has now a universal Hep C screening recommendation. We have easy to follow streamlined guidelines and testing, even for primary care providers to follow. We still have important frontiers we need to move on, which include decentralizing increased frontline involvement, getting more primary care, co-localized care, community-based testing, and diagnostics too. So potentially point of care hep C RNA testing, but all of this is really helping to shift care where patients don't have to come to us, but that we're actually delivering care where patients are in the communities. So, and just a reminder, there's a lot that the patients and the community members can do in partnership to improve that outreach and to optimize programs. So in so many areas, we've seen peer support and peer navigators really get to people who are otherwise unable to be reached by traditional healthcare. Our community-based support services are really helpful to enable and support patients to get the services. They provide a lot of healthcare promotion and education through health fairs and other literature, and they just do such a great job. I think even primary FQHCs and all of these standalone community services that are providing other services, they know how to reach populations with the barriers. They've been working with them for a long time. So it could be in-language support, insurance and health coverage assistance. They're trusted partners in providing other services. And this is where we think potentially they'd be frontline workers. Obviously, it's been so successful with hep C, but with other liver diseases as well, we need to think about this. So, and we see a lot of this with a lot of the members who are part of active in AASLD. You guys are doing such great work supporting patients. And I think this is important for providers to see that when you see a patient with NASH or PSC or autoimmune hepatitis, make sure you connect them with a support group or an organization that they can turn to. So to find other people who are living with the disease, they can actively engage with people who are doing the same thing as they are. And there's no reason for somebody to go the journey alone. And tapping into one of these support groups is a great way not to feel alone and also to just delve into the wealth of information that other patients have. So kudos to all of you guys doing this work on the ground. So next, we're going to talk about how patients are the largest and least utilized resource in healthcare, and how we can really incorporate patients into the research and the work that we do. So our understanding of disease is incomplete without the patient experience. And this is just really highlighting what I was talking about, how when you get a patient in the room with you, it's not just the liver, it's the whole person. So we do need to focus on the whole person lived experience of not just the liver. And living with the liver disease is not just a person's blood work, their ultrasound result, what medication they're taking, or even the symptoms they report. Patients are not their disease and they're not patients all the time. What we see in clinic is really just a small part of the whole person. So this diagram is just looking at Hep B and really looking at how it has many psychosocial effects. So there's often a greater burden on patients in the psychosocial realm than what we see with physical symptomatology, because it is often asymptomatic and how their lab test might look. So what you have here, you can see their primary impacts, which include the fear of disease progression. So with viral chronic hepatitis, people are often very afraid of liver cancer. Financial loss if there's discrimination with work or education, and fear of infecting others is often a very real fear and a guilt that they may be transmitting this to their loved ones. There's secondary impacts like how a person might experience stigma and discrimination from the community and institutions, including even healthcare providers. And you hear many stories of this, of how they just feel like they're not treated right by the front desk staff, or how even physicians may judge them for how they got their infection or diagnosis. And tertiary impacts would include how this then leads to loneliness and withdrawal to society and other effects. That's just one example. Obviously, with many disease states, there are going to be similar type things. Hepatitis is just one of the things I know best. So I'll be sharing from some of those experiences. So how do we report the entirety of this patient experience of living with the disease, or what we call, call patient-reported outcomes? So Institute of Medicine describes this as any report of the status of a patient's health condition, which comes directly from the patient without interpretation of the patient's response by a clinician or anyone else. So this is an important link in catching outcomes that are actually meaningful to patients, and the reason that they may have sought care in the first place. So it captures more of that lived experience with a condition and its impact on the many aspects of a patient's life. So I love this commentary that I saw recently on the role of PRO. Can we consider PRO to be one of these emerging biomarkers in chronic liver disease research? They could be used more widely as clinical endpoints for treatment trials. We could correlate this with disease stage and other biomarkers. There's some data on NASH, and even use these as prognostic variables. And I would add, even beyond research, I think that this could be used more regularly in clinical care. And though we haven't done it in our practice, I can see how we could begin using this along with our visits, where patients could potentially fill out surveys and forms on PROs before we see them, and we could use it along with all the information we get during an interview. So there are many PRO tools that have been used in liver disease, and I think there'll be more and should be more as we do more research. So here's just a list of some of them. We commonly look at HRQL, or health-related quality of life. There's some well-validated satisfaction and functional status surveys, such as the SF36. There are liver disease-specific questionnaires, the CLDQs, which have been validated in Hep C, NAFLD, and NASH. There's a PSC PRO. Work productivity is something we'll look at, fatigue, and there are many more. NIH has a database, a PRO survey database, which has more than 300 measures that are often used in research. So I just want to talk quickly about one study I thought was really interesting. This is a Hep C PRO study. The objective was to evaluate the impact of DAA therapy on symptoms and functioning in a large real-world population. This was done in multiple sites. You can see the many authors below. It was funded by PCORI, the Patient-Centered Outcomes Research Institute. And it's one of the defining features of PCORI grants is that there's supposed to be patient engagement with development of research proposal and the execution, so on every step of the way. So the belief is that patient engagement or meaningful involvement of patients throughout the research cycle, from design to implementation to dissemination, will lead to the research being more patient-centric, relevant, useful, transparent, and there will be a greater trust and uptake of the study results by patients, providers, and other stakeholders. So in this study, they had patients affected by Hep C directly inform the development outcomes and the execution of the study. And so it's good to look through kind of what we mean by patient engagement. And there are different levels of it. So, most commonly we think of patients participating at the bottom. So this is the most way we talk about patients being involved. And this is just where patients are subjects, or they might participate in your study, or they are the endpoint. So they have things done to them, but they don't necessarily have a role beyond that, being a participant. So next up would be a higher level of engagement, where the researchers may share the information and knowledge about research after it's complete, or patients may help recruit other patients, or they might provide some satisfaction survey or something like that. But it's actually important to get to the higher level involvement, where patients and communities are working alongside with researchers or program designers to actually plan, design, manage, evaluate, and even disseminate research. And this is where I think you really tap into how patients can improve the work that's being done. So in this prop-up study, they formed a patient engagement group. There were 7 people affected by Hep C. It was a mix of people who had been treated, untreated, cured, not cured, or contemplating treatment. It was a diversity of men, women, ethnicities, and age groups. They met ongoing, developed their own missions, goals, scope of work. They were reimbursed for their time, and they were viewed as full partners, fully integrated with the team. So one of the first tasks for them was to decide which harms and benefits were most important to patients making decisions regarding Hep C treatment, like whether or not they were going to start treatment. So when they were asked which concerns are important to you, how do you rate these concerns? So cure rate, side effects, harm to pocketbook, harm to your functioning, harm to your liver, long-term survival, benefits to other conditions or benefits to function, you see that they rated everything really high. So almost everything is pretty important to extremely important. So it's kind of hard to sift through that. But then they asked them to rank these things. And this is where you really see how things tease out. And the highest priority was the cure rate. They wanted to know how effective the treatments would be. And then second most important was the harm to the pocketbook. Following that were side effects, then harm to liver, harm to other conditions, harm to functioning. And then third to the last is actually long-term survival. And I think this is really interesting because in the scientific community, long-term survival is one of the things we look at, most, and it's often the thing that reviewers look at, and when we look at analysis and meta-analysis and we do literature review to know whether things work, we look at long-term survival. And maybe it's that patients realize, we're all going to die eventually, and that, what's important to them in their day-to-day is how it's affecting them day-to-day. So the harm to the pocketbook, is their family going to suffer financially from this? Are they going to have a difficult time going through the day-to-day because of the side effects? And overall, the cure rate, is this worth those sacrifices? So I think this is just really important to see, and should be reflected in kind of the research that we're doing. So next is just looking at PRO has been developed for NASH called NASH Check. And I think our Donna Cryer was a part of this. And this was developed to be used as a trial endpoint. It was put together based on literature review and concept elicitation from patient interviews. They recruited non-cirrhotic patients. And they found that the main symptoms that were reported were pain in the right upper quadrant, poor sleep quality, impaired memory, and reduced focus. And they did, for all these measures, should be validated. And they did content validation through cognitive debriefing, where they went backwards to see if the questions meant what they thought it meant to the patients. So in the end, you kind of see that this is a very multifactorial kind of assessment, utilizing symptoms, also activity limitations, social impact, like how it's impacting people's personal relationships with their spouse or their friends and family, the impact psychologically on their confidence, self-esteem, and even economic impact, work productivity, and things like this. So it just kind of really covers many, many aspects of a person's life. So with NASH specifically, that you were able to see here, the higher bars are the ones where people are reporting more of an impact. So the highest one was that NASH was having an impact in people making healthy eating choices. So that's good. And there was, some reported difficulty. Some people had immobility and functional abilities, some stigma. I was surprised to see the level of stigma that some people are reporting. And this is important because as physicians, we may not consider this. One of the good things is we see very, very low reported impact on people's ability or motivation to work. And again, these are non-cirrhotic patients. So with PRO and cirrhosis, there's quite a work being done here. I'm not going to go over it. These are some slides shared to me by Elliot Tapper, just showing similarly a lot of many dimensions involved in looking at PROs and cirrhosis. And I just want to make sure people know that there's an excellent session on patient empowerment in improving quality of cirrhosis. And this is today at 2:30, so don't miss that. And we'll move on from that. And I think one of the things to say is that it's important to ask these questions because we do have options for people. So if we ask people about sleep or sexual activity or itching or muscle cramps, that we do have therapeutic or lifestyle options for them. So it is important to ask because we can then offer ways of helping people. So I want to get into how important it is to get patients involved as we develop new therapies. I'm going to use Hep B as an example because we are in this exciting time of new therapy development, and why our patient perspectives are important in the development of Hep B cure. Well, first, we want to clarify the rationale for finding a cure. Why does cure matter? Well, we think it will help prevent liver cancer, but also will help people in many, many parts of the world and in many settings. Oftentimes people are discriminated against based on their Hep B status, and the risk of transmission obviously would be resolved too. So it's important to elucidate those things. To understand if the proposed treatment interventions would be useful. Is the cure that I'm proposing going to be practical in the real world? And we'll be having a session on this as well at 11:30 today, talking about the different options that are being researched, and some of them involve injections. And is this something that's practical and that patients will be agreeable to? Third, we want to avoid any intentional harm to the affected community. Are we potentially somehow exacerbating stigma in our work? And lastly, we want to maintain a trusting and respectful relationship between the scientific community and the affected communities. And this is really important too, especially if you're trying to get more involvement in patients to get screened, to get tested. A lot of people don't even want to get screened for Hep B because they feel like it's potentially a death sentence and that they'll be stigmatized. And so they see that there's something that can be done about it. They may be more likely to get tested. So one of the nice initiatives that's been happening more of as well is patient-focused drug development. This is a FDA initiative to obtain the patient perspective on specific diseases and their currently available treatments. These can be done led by FDA or externally led. Hepatitis B Foundation led one last June. It was remote, and they addressed two main topics, which are basically the two questions that all of these PFDDs has is, what is it like living with a condition? So they have a panel of patients talk about their experience. And then what is the perspective on current and future approaches to treatment? And this was a group facilitated discussion that had polling questions. We had participants from all over the world. And so it was nice to hear feedback directly from patients. And I see that there's a NASH one coming up too. So it's great to see more of these things happening. All right, and then patient-centric clinical trials are something that would be good to see more of as well. So these basically mean that we're involving patients in the design and execution of clinical trials. And by having them design with patients, we can improve their relevance to patients and encourage participation in the trials. So this potentially could impact your inclusion or exclusion criteria, the visit burdens, and what patient-relevant outcomes might be looked at. And what some of the studies are showing is that patient-centered trials are much more likely to produce drugs that actually launch, 87% versus standard trials, 68%. And also, they are more likely to be able to enroll patients quickly. So in these that were studied, the average time to enroll 100 patients for patient-centric trials was about 5 weeks as opposed to 5 months as opposed to more than 12 months in a lot of these other these standard trials. So the lighter color one, where you see the shorter bars, those are patient-centered trials, and you can see they were able to reach 100 patients recruited much faster than the darker trials, which were all the standard trials. So we're going to talk about driving awareness and education. This is the last part next to last part. So this is about education. So AASLD has done such a great job about really tailoring education towards patients. We have a number of things out there that we encourage people to disseminate and use. There are also patient-focused guidelines. We have a couple coming up. And these patient-focused summaries, some are available now. I love the autoimmune hepatitis one. You see this nice art that was done by Nancy Rose's daughter right here, where you see the liver, the immune cells attacking the poor liver. And I just think it's great to be able to really translate our scientific knowledge into understandable things for patients. And we've had a number of great webinars. The one here I'm featuring is the fact and fiction of patients with chronic liver disease, what we should know about COVID. And Karen Hoyt was our moderator, and I was honored to be a part of this. And here's one on PSC that just happened. And there have been a number of other ones that I don't have here, but there are recordings for all of these. So if you missed this, definitely get onto the website to find more. It's just really important to make sure that science trickles down to the patients. We need to update the patients in the community with all of our research discoveries. It's important if we can do plain English summaries for medical publications so people know what this means for them. And an educated population is better prepared for breakthroughs. So in the case of the Hep C DAAs, we wanted people to be ready for these remarkable breakthroughs, but that meant that people needed to be aware that there were new therapies that worked. And also insurance companies needed to be prepared, and they weren't prepared. And that's why we had so many difficulties with getting pre-authorizations and why there were so many restrictions with this. So it's really important to have a wider audience know about what's happening. It also creates demands too, where patients are asking their physicians to be screened and for treatment. And this is just an example on the right where more and more scientific meetings are having side sessions directly for patients. And this was something that happened at the International Hep B meeting a couple months ago. It was a forum just for community members where we had speakers kind of talk about, what the research and the scientific meeting meant for patients. Of course, patient storytelling is so important. We know personal stories are really compelling. It brings in the empathy to the knowledge, and it's really effective for advocacy. It's impactful for policymakers, legislators, funders when they see that these are real people that they're serving that are impacted, and it brings the data to life. You know, I think we've had so much good data already on liver disease, and yet it hasn't necessarily compelled any changes in policy. And going hand in hand to Congress and and whatever advocacy with the patients and physicians coming together to advocate together is really powerful. It's also effective for health communication. People can see, oh, this could happen to me as well, and it dispels stigma. So on the right, I have the voices from MVHR, Voices for HEP Community. They all have their stories online. On the bottom, there's a stigma report that's coming out about people living with Hep B, and we're hoping to really fight stigma and discrimination through stories. Here's some more examples of storytelling. Bakari Sellers shared about his daughter having a pediatric liver transplant, and he was featured by ALF, and his story was very powerful. GLI has a number of storytelling workshops, which are really activated a lot of people. And Hep B Foundation has Just Be program with a number of really great studies. They basically train patients to tell their stories and create videos. And it's really been amazing too. And that's Jackie Chan that was in that picture. And patients and community voices really create movements and have done so much work in the social media field. And this is just a glimpse of some of the campaigns that have been out there. Liver Cancer Awareness Month was just in October. World Hepatitis Day is July 28th. There's International NASH Day. There's Global PSC Awareness Day. There's probably others that I wasn't able to put up here, but definitely tap into all of those. And finally, partnering to make an impact on advocacy and policy. So this is one of my favorite quotes: "Nothing about us without us." Just talking about any of the efforts that we do to combat disease really need to include those of us in the patient community. So I think what happened in the HIV/AIDS movement is just really important for us to remember. And they just had such an incredible movement led by the affected community and driven by the affected community. And these individuals, as people were dying, recognized that unless we fight for our lives, we shall die. And there was that urgency and passion that came behind so much of what they did. And in this Denver principle on the right, the community declared that they were people with AIDS. They weren't patients. They didn't want to be labeled as victims or helpless, and they were only occasionally patients. So they wanted to be called people with AIDS. And they put out recommendations that they should be involved with every level of decision-making, including all AIDS forums with equal credibility as all other participants. And many of you will remember they stormed the FDA, they stopped FDA, they stormed the HHS, and they really accelerated actually drug approvals because of what they did, they needed more options. And it was just interesting to see, not your traditional way of getting things done, but it certainly was effective at that time. So what can we learn from how the AIDS meetings are run, which I think is very interesting. IAS is the AIDS meeting, global AIDS meeting happens every other year. And they have this ethos behind community representation and participation meetings. And they recognize that it will take the combined efforts of all stakeholders in public and private sectors and civil society to reverse the AIDS epidemic. And so they actually encourage activism and advocacy because they recognize that it advances commitment, policy, and practice. And they support full participation. They have something called the Global Village, which is a diverse and vibrant space where communities from all over the world gather to meet and share and learn from each other. On the right here, you see these people holding up the umbrellas, really advocating for representation of sex workers. And here you see in the Global Village, it really blends the scientific sessions with cultural activities, live performances. It's a networking zone, a lot of NGO booths and marketplace and art exhibits. So it's very dynamic and vibrant. So I'll say we have a little of that here going on at some of our liver meetings. This is a picture of what happened 2 years ago, the last time we were in person in Boston at AASLD. A number of us held a freeze mob, and it was right outside the Heinz Center. And we did a little chanting, we will rock you. It was more like, we will test you. We will treat you. We have a video of it. It was just a really nice demonstration of how important we think all this work is that needs to be done with testing, screening, and treatment of people with hepatitis. And you see here Michael Nimberg saying, brother, can you spare a dime for hepatitis? And he did collect $8. So making small progress here. And at the bottom is a picture of the No Hep Village, which was done at the Global Hepatitis Summit in Toronto, where we had a similar type, kind of like the Global Village, but a village of all community members where we could gather and have our own lineup of events alongside the scientific sessions. So just, it's so important if we can identify and energize the millions of people living with liver disease, right? If we can do that, we can add and really have such an impact in how we combat stigma, how we increase awareness, demand access, improve our program delivery. And like we're doing here, this is how we can partner with scientists, researchers, and policy makers. And my vision is that next year we'll have double the number of advocates of patients registered and really see a movement. And I've seen this just in my work with the Alliance as a nonprofit. It's been amazing just to see the history of what we've done. And I wasn't here at the beginning, but the Alliance was founded in 2007 as just a group of Hep C patients who wanted to see more done. And in 2008, they led the first community-led World Hepatitis Day. I hear it was in a hotel outside of WHO. And they really just kept pushing. They just kept pushing for viral hepatitis to be on the WHO agenda. There was nobody on the WHO team whose title included hepatitis. And so they advocated, they actually got funding for people to be on the staff to focus their work on hepatitis. And now we have official World Hepatitis Day. The community advocated for the global health sector strategy to include hepatitis and actually commit to viral hepatitis elimination, which was adopted in 2016. And we continue to push. So I just think it's neat to look back and see how important it is for advocates to do more. And I think this is true. Elimination will not be achieved without affecting people who are affected by viral hepatitis. And I'd say the same about every liver disease. We're not going to be successful unless we really incorporate the people who are most affected. And we've had a number of successes in the US as well with Advocacy, number of bills that have been introduced. Most recently, the Liver Act was reintroduced in October. There is a NASH Care Act as well. California had a great success where they have, it's now required by institutions to offer free Hep B and Hep C screenings and linkage to care. And, of course, with Hep C, we know that there's been such a fight to get the restrictions lifted for DAAs, and it's been neat to see the progress there because of the advocates. For Hep B, at some point, Vemlidy fell off the list of covered medications, leaving a lot of patients stranded without options. And it was really the advocates, Hep B Foundation, leading the way to get it re-added. So let's remember, no one is more motivated than patients to drive progress against their disease. And that's how I want to close. Just so many ways where we've seen patients having impact. Let's continue the conversation and do more work in this area. And I don't think we have too much time for questions, but I do think there were a number of things Wayne and I thought might be good for discussion. If anybody wanted to, chime in and talk about what are some experiences you've had with good patient partnerships or bad, or what you think you wish you knew your doctor knew about living with liver disease, what it's like. What we could do, what we could use more, where do you think we could use more patient engagement in liver disease care research? And how do we activate more people living with liver disease to be involved? And in what realms do we think we need more advocacy? So Wayne, do you want to add anything or?
Well, I think I wish we had another hour.
I know.
I feel like we're just run out of time. So I'd really like to thank everybody for attending. Connect with us in the sessions if you want to talk about any of these things. We'll be around and be happy to visit with anybody that wants to pursue any of these. But I think we need to sign off and get ready to go on to the next set of programs.
Yeah, this is great. And that's a great welcome. I think, Wayne, that's a good idea. People can reach out to us, and I think there'll be other opportunities in other forums for people to discuss. Thanks, everybody.
Thank you so much, everybody.